Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of transient tachypnea of the newborn, one of the most common causes of respiratory distress in the neonatal period. This condition is frequently encountered in term and late preterm infants, particularly those born by cesarean section without labor. We will work through 14 carefully designed clinical cases covering pathophysiology, clinical presentation, examination findings, imaging interpretation, laboratory investigations, management strategies, and long-term associations. This lecture is designed for general pediatric physicians and trainees. Let us begin. Case 1. A 38-week gestation newborn is delivered by elective cesarean section without labor. At 1 hour of life, the nursing staff reports the following findings. Vital signs: respiratory rate 72 breaths per minute, heart rate 150 beats per minute, oxygen saturation 94% on room air, and temperature 36.8 degrees Celsius. On physical examination, the infant is alert and responsive with mild subcostal retractions and nasal flaring. No cyanosis is observed, feeding attempts are successful, and breath sounds are clear bilaterally. Which of the following is the most likely diagnosis? Option A, respiratory distress syndrome. Option B, meconium aspiration syndrome. Option C, neonatal sepsis. Option D, transient tachypnea of a newborn. The correct answer is option D, transient tachypnea of the newborn. The key pathophysiology here is delayed clearance of fetal lung fluid. During normal labor, a catecholamine surge activates epithelial sodium channels in the lung, switching the alveolar epithelium from fluid secretion to active fluid reabsorption. Elective cesarean section without labor bypasses this critical surge, leaving residual fluid in the alveoli after birth. Regarding risk factors, maternal factors include diabetes and asthma. Delivery factors include elective cesarean section without labor and rapid delivery. Infant factors include male gender, late preterm gestation, and macrosomia. This case perfectly illustrates the classic combination of elective cesarean section plus mild respiratory distress with good perfusion. Case 2. A 36-week gestation infant is delivered via scheduled cesarean section due to breech presentation. The mother had an uncomplicated pregnancy with no history of diabetes or prolonged rupture of membranes. Labor was not attempted prior to delivery. The infant appears well immediately after birth with normal APGAR scores, 8 at 1 minute and 9 at 5 minutes. Initial vital signs are stable. However, at 3 hours of life, nursing staff notices the infant has developed tachypnea with a respiratory rate of 68 breaths per minute, mild nasal flaring, and intermittent grunting. What is the most typical time frame for the onset of symptoms in transient tachypnea of the newborn? Option A, within 30 minutes of birth. Option B, between 6 to 12 hours after delivery. Option C, within the first 2 to 6 hours of life. Option D, after 24 hours of age. The correct answer is option C, within the first 2 to 6 hours of life. This is the defining temporal feature of transient tachypnea of the newborn and gives the condition its name. Symptoms typically appear within the first 2 hours, reach peak severity around 2 hours, and then plateau around 6 hours. Gradual improvement then begins around 24 hours, with complete resolution in most cases by 48 to 72 hours as fetal lung fluid clears naturally through pulmonary and lymphatic circulation. This self-limited course with natural resolution without specific treatment is one of the hallmarks distinguishing transient tachypnea of a newborn from more serious conditions such as respiratory distress syndrome or pneumonia. There are no long-term respiratory effects in typical cases. Case 3. A 38-week gestation infant born via cesarean section presents with tachypnea at 2 hours of life. The baby appears alert and responsive. Vital signs show a respiratory rate of 82 breaths per minute, heart rate 155 beats per minute, and oxygen saturation 94% on room air. The infant has good muscle tone and appropriate reflexes. Which physical examination finding is most characteristic of uncomplicated transient tachypnea of the newborn? Option A, severe intercostal and subcostal retractions with accessory muscle use. Option B, mild nasal flaring with minimal subcostal retractions. Option C, cyanosis of lips and nail beds despite supplemental oxygen. Option D, absent breath sounds with dullness to percussion bilaterally. The correct answer is option B, mild nasal flaring with minimal subcostal retractions. This is the key clinical teaching point for transient tachypnea of the newborn. The signs of respiratory distress are mild, not severe. The tachypnea can be significant, ranging from 60 to 100 breaths per minute, but the retractions are subcostal and intercostal rather than severe. Nasal flaring is present but not marked. Expiratory grunting may be mild and intermittent, and breath sounds are clear to slightly decreased with no crackles. The infant remains pink with good perfusion and minimal cyanosis. The Silverman-Anderson score, which grades 5 components including chest movement, intercostal retractions, xiphoid retractions, nasal flaring, and expiratory grunt each from 0 to 2, is typically low in transient tachypnea of the newborn. Severe retractions or marked cyanosis should raise suspicion for alternative diagnoses. Case 4. A 38-week gestation newborn delivered by elective cesarean section presents at 3 hours of life. Vital signs show a respiratory rate of 68 breaths per minute, mild subcostal retractions and nasal flaring, oxygen saturation 94% on room air, alert and responsive with good muscle tone, and no cyanosis or grunting. On lung auscultation, you note slightly diminished breath sounds bilaterally with no adventitious sounds. No crackles, wheezes, or rhonchi are heard. Which condition is most consistent with these auscultatory findings? Option A, respiratory distress syndrome. Option B, neonatal pneumonia. Option C, transient tachypnea of the newborn. Option D, meconium aspiration syndrome. The correct answer is option C, transient tachypnea of the newborn. In this condition, retained fetal lung fluid causes interstitial edema without significant alveolar involvement. This results in clear to slightly decreased breath sounds with no adventitious sounds, which distinguishes it from other neonatal respiratory conditions. In respiratory distress syndrome, you would expect diminished breath sounds with fine crackles and air bronchograms on imaging. In pneumonia, you would hear coarse crackles or rhonchi with focal consolidation. In meconium aspiration syndrome, you would find coarse wet sounds with wheeze and asymmetric findings. The absence of any adventitious sounds in a tachypneic term neonate born by cesarean section is a key pointer toward transient tachypnea of the newborn as the diagnosis. Case 5. A 38-week gestation infant born via elective cesarean section without labor develops tachypnea within the first hour of life. The baby has mild subcostal retractions and nasal flaring, but remains alert and responsive. Chest X-ray shows hyperinflated lungs with prominent parahilar markings and fluid in the minor fissure. Which of the following best describes the primary pathophysiological mechanism responsible for this infant's respiratory distress? Option A, inadequate surfactant production leading to alveolar collapse. Option B, inflammatory response causing increased pulmonary vascular permeability. Option C, delayed clearance of fetal lung fluid from alveolar spaces. Option D, congenital structural abnormality of the respiratory tract. The correct answer is option C, delayed clearance of fetal lung fluid from alveolar spaces. During fetal life, the lungs actively secrete fluid to maintain expansion, driven by chloride secretion into the alveolar space. During labor, the catecholamine surge activates epithelial sodium channels, known as ENA-C channels, which switch the epithelium from fluid secretion to active sodium reabsorption. Water follows sodium out of the alveoli, and residual fluid drains via lymphatic circulation. When cesarean delivery occurs without labor, this catecholamine surge is absent. The ENA-C channels are not adequately activated, and fetal lung fluid remains in the alveolar spaces, impairing gas exchange. Surfactant deficiency causes respiratory distress syndrome, not transient tachypnea of the newborn, and structural abnormalities would present differently on imaging. Case 6. A 38-week neonate born via elective cesarean section develops tachypnea within 2 hours of birth. The neonatology team explains to the parents that the baby's lungs are still clearing fluid that was normal during pregnancy. The attending physician mentions that specific ion channels must activate to pump sodium and water out of the air sacs. Which cellular mechanism is most critical for the transition from fetal lung fluid secretion to postnatal fluid absorption? Option A, activation of chloride channels in pneumocytes. Option B, increased surfactant production by type II cells. Option C, enhanced calcium transport across alveolar membranes. Option D, upregulation of epithelial sodium channels. The correct answer is option D, upregulation of epithelial sodium channels. Epithelial sodium channels are the molecular gatekeepers of the fetal to neonatal lung fluid transition. During labor, catecholamines, specifically epinephrine and norepinephrine, bind to receptors on the alveolar epithelial cells and activate these sodium channels. Sodium moves from the alveolar lumen into the cell and then into the interstitium, creating an osmotic gradient. Water follows sodium passively out of the alveoli clearing the air spaces for gas exchange. When cesarean delivery bypasses the labor process, this catecholamine surge does not occur. The epithelial sodium channels remain inactive, and fluid cannot be efficiently reabsorbed, resulting in transient tachypnea of the newborn. Case 7. A 38-week gestation infant born via elective cesarean section develops tachypnea within 2 hours of birth. The respiratory rate is 68 breaths per minute with mild subcostal retractions and nasal flaring. Oxygen saturation is 94% on room air. The infant appears alert and is attempting to feed. A chest X-ray is obtained to evaluate the respiratory distress. Which of the following chest X-ray findings is most characteristic of transient tachypnea of a newborn? Option A, bilateral ground glass opacities with air bronchograms. Option B, hyperinflated lungs with prominent parahilar streaking. Option C, patchy consolidation with pleural effusion. Option D, complete whiteout of both lung fields. The correct answer is option B, hyperinflated lungs with prominent parahilar streaking. There are 3 classic radiographic features of transient tachypnea of a newborn that you must memorize. First, hyperinflated lungs with increased lung volumes due to air trapping, flattened diaphragms, and expanded intercostal spaces. Second, prominent parahilar streaking, which represents engorged lymphatic vessels draining retained fluid, appearing as linear densities radiating from the hilum. Third, fluid in the interlobar fissures, most commonly the horizontal fissure, which is considered a pathognomonic finding for transient tachypnea of the newborn. In contrast, respiratory distress syndrome shows ground glass opacities with air bronchograms and hypoinflated lungs. The pattern of hyperinflation plus parahilar streaking in a term cesarean-born infant is classic for this condition. Case 8. A 38-week gestation neonate born via elective cesarean section develops tachypnea within 2 hours of birth. Initial chest X-ray shows hyperinflated lungs with prominent parahilar markings. The neonatal intensive care unit team decides to perform bedside lung ultrasound to further evaluate the respiratory distress and differentiate between transient tachypnea of the newborn and other neonatal respiratory conditions. On lung ultrasound examination, which finding would be most characteristic of transient tachypnea of the newborn? Option A, bilateral white lung appearance with apsinae lines. Option B, double lung point sign with upper aerated zones. Option C, multiple consolidations with air bronchograms. Option D, massive pleural effusion with lung collapse. The correct answer is option B, the double lung point sign with upper aerated zones. The double lung point sign is the characteristic lung ultrasound finding in transient tachypnea of a newborn. It describes a sharp demarcation between aerated upper lung fields, which show A lines, and fluid-filled lower fields, which show coalescent B lines. This pattern reflects the gravitational distribution of retained lung fluid, which settles in the dependent lower zones while the upper zones remain relatively aerated. This finding has high sensitivity and specificity for transient tachypnea of the newborn diagnosis and distinguishes it from respiratory distress syndrome, which shows a generalized white lung pattern bilaterally. In practice, if a double lung point is present on bedside ultrasound, consider transient tachypnea of the newborn. If absent, evaluate for respiratory distress syndrome or pneumonia. Lung ultrasound can guide targeted respiratory support decisions in the neonatal intensive care unit. Case 9. A 38-week gestation infant born via elective cesarean section develops tachypnea at 3 hours of life. Physical exam reveals a respiratory rate of 68 breaths per minute, mild subcostal retractions, and oxygen saturation of 91% on room air. The infant appears alert and responsive, but has not initiated feeding. Temperature is stable at 36.8 degrees Celsius and heart rate is 155 beats per minute. There is no maternal fever or prolonged rupture of membranes. Which of the following arterial blood gas findings is most consistent with transient tachypnea of a newborn? Option A, pH 7.25, carbon dioxide partial pressure 55 millimeters of mercury, oxygen partial pressure 65 millimeters of mercury, bicarbonate 22 milliequivalents per liter. Option B, pH 7.35, carbon dioxide partial pressure 45 millimeters of mercury, oxygen partial pressure 75 millimeters of mercury, bicarbonate 24 milliequivalents per liter. Option C, pH 7.45, carbon dioxide partial pressure 35 millimeters of mercury, oxygen partial pressure 85 millimeters of mercury, bicarbonate 23 milliequivalents per liter. Option D, pH 7.20, carbon dioxide partial pressure 65 millimeters of mercury, Oxygen partial pressure 45 millimeters of mercury, bicarbonate 20 milliequivalents per liter. The correct answer is option B, pH 7.35. Carbon dioxide partial pressure 45 millimeters of mercury. Oxygen partial pressure 75 millimeters of mercury, bicarbonate 24 milliequivalents per liter. This represents mild hypoxemia with compensated respiratory acidosis, the classic blood gas pattern in transient tachypnea of the newborn. The retained lung fluid causes ventilation-perfusion mismatch, producing mild hypoxemia. Infants compensate by increasing their respiratory rate, which maintains adequate carbon dioxide elimination and keeps the pH near normal. Expected values are pH normal to mildly acidic in the range of 7.3 to 7.35, carbon dioxide partial pressure normal to slightly elevated at 40 to 50 millimeters of mercury, oxygen partial pressure mildly decreased at 60 to 80 millimeters of mercury on room air, and base excess usually normal. A key clinical pearl: normal pH with mild hypoxemia in a term infant strongly suggests transient tachypnea of a newborn rather than more serious conditions like respiratory distress syndrome or sepsis. Case 10. A 38-week gestation newborn delivered via elective cesarean section develops tachypnea within 2 hours of birth. Physical examination reveals respiratory rate 75 breaths per minute, heart rate 155 beats per minute, temperature 36.8 degrees Celsius, mild subcostal retractions and nasal flaring, no cyanosis, alert and responsive, and oxygen saturation 88% on room air. The infant appears comfortable but has persistent tachypnea. Chest X-ray shows hyperinflated lungs with prominent parahilar markings. What is the most appropriate first step in managing this infant's oxygenation needs? Option A, immediate intubation and mechanical ventilation. Option B, start nasal cannula oxygen at 0.5 to 1 liter per minute. Option C, begin high-flow nasal cannula at 4 to 6 liters per minute. Option D, initiate continuous positive airway pressure at 5 centimeters of water pressure. The correct answer is option B. Start nasal cannula oxygen at 0.5 to 1 liter per minute. The target oxygen saturation in term newborns with transient tachypnea of the newborn is 90 to 95%. Management follows a stepwise escalation approach. Level 1 is room air for infants with oxygen saturation above 90% and minimal distress. Level 2 is low-flow nasal cannula at 0.5 to 1 liter per minute, which is appropriate here because the saturation is 88% with mild distress, targeting 90 to 95%. Level 3 is high-flow nasal cannula at 2 to 6 liters per minute for persistent hypoxemia. Level 4 is continuous positive airway pressure at 4 to 6 centimeters of water for persistent distress or apnea. A key clinical pearl: most transient tachypnea of the newborn cases resolve with minimal oxygen support within 24 to 48 hours. Avoiding hyperoxia, defined as saturation above 98%, is equally important. Case 11. A 38-week gestation infant born via elective cesarean section develops tachypnea at 2 hours of life. Initial management with low-flow nasal cannula oxygen at 2 liters per minute improved oxygen saturation from 88 to 93%. However, at 6 hours of life, the infant continues to have respiratory rate 68 breaths per minute, moderate subcostal and intercostal retractions, oxygen saturation 91 to 92% on 2 liters per minute nasal cannula, alert and responsive but with increased work of breathing, and chest X-ray showing hyperinflated lungs with prominent parahilar markings. Which intervention would be most appropriate to improve functional residual capacity and reduce work of breathing? Option A, increase nasal cannula flow to 4 liters per minute. Option B, initiate continuous positive airway pressure at 5 to 6 centimeters of water. Option C, begin high-frequency oscillatory ventilation. Option D, administer inhaled bronchodilators. The correct answer is option B. Initiate continuous positive airway pressure at 5 to 6 centimeters of water. Continuous positive airway pressure is highly effective in moderate transient tachypnea of the newborn management through several mechanisms. It recruits fluid-filled alveoli and improves functional residual capacity by preventing end-expiratory alveolar collapse. It reduces work of breathing through positive end-expiratory pressure. It maintains alveolar patency while natural fluid clearance continues to occur. It provides gentle respiratory support without requiring invasive ventilation. Studies show that continuous positive airway pressure at 5 to 6 centimeters of water reduces oxygen requirements and shortens recovery time in moderate cases. Parameters to use: starting pressure 5 to 6 centimeters of water, Inspired oxygen fraction starting at 0.3 to 0.4 and weaned as tolerated, using nasal prongs or mask as the interface, and monitoring oxygen saturation, respiratory effort, and comfort. Case 12. A 38-week gestation newborn delivered by elective cesarean section develops tachypnea at 3 hours of life. Current vital signs show respiratory rate 90 breaths per minute, heart rate 155 beats per minute, oxygen saturation 91% on room air, and temperature 36.8 degrees Celsius. The infant appears alert, but has moderate subcostal retractions and nasal flaring. Parents are asking about feeding. Chest X-ray shows hyperinflated lungs with prominent parahilar markings consistent with transient tachypnea of the newborn. Which of the following is the most appropriate nutritional management for this infant? Option A. Begin oral feeding with standard formula every 3 hours. Option B. Start intravenous fluids and delay all oral intake. Option C. Attempt breastfeeding with close monitoring for aspiration. Option D. Initiate nasogastric tube feeding with breast milk. The correct answer is option B. Start intravenous fluids and delay all oral intake. This is a critically important safety principle in managing tachypneic neonates. Infants with transient tachypnea of the newborn and respiratory rates above 60 breaths per minute should remain nil by mouth to prevent aspiration risk. Tachypneic infants have impaired coordination of the suck-swallow-breathe reflex, significantly increasing aspiration risk during any feeding attempt. Intravenous fluid therapy at 80 milliliters per kilogram per day provides adequate hydration while avoiding fluid overload that could worsen pulmonary edema. The feeding protocol by respiratory rate is as follows. Above 70 breaths per minute, maintain strict nil by mouth with intravenous fluids at 60 to 80 milliliters per kilogram per day. 60 to 70 breaths per minute, consider nasogastric tube feeding. Below 60 breaths per minute, a trial of oral feeding can begin. Feeding can be safely resumed once the respiratory rate stabilizes below 60 breaths per minute. Case 13. A 38-week gestation infant born via elective cesarean section was initially diagnosed with transient tachypnea of the newborn after presenting with mild tachypnea. At 12 hours of life, the infant's condition deteriorates significantly. Current findings include severe tachypnea with a respiratory rate of 85 breaths per minute, marked cyanosis despite 60% oxygen, oxygen saturation dropping to 78% on high-flow oxygen, significant intercostal and subcostal retractions, grunting respirations becoming more pronounced, blood pressure 65 over 40 millimeters of mercury, which is borderline low, and heart rate 175 beats per minute with poor peripheral perfusion. What is the most likely serious complication that has developed? Option A. Secondary bacterial pneumonia with sepsis. Option B. Persistent pulmonary hypertension of the newborn. Option C. Spontaneous pneumothorax. Option D. Congenital diaphragmatic hernia. The correct answer is option B. Persistent pulmonary hypertension of the newborn. This case illustrates the serious complication known as malignant transient tachypnea of the newborn. This occurs when severe fluid retention leads to pulmonary vascular compromise. The increased pulmonary vascular resistance triggers right-to-left shunting through fetal channels, exactly as discussed in the persistent pulmonary hypertension of the newborn lecture. This serious complication develops in approximately 5 to 10% of severe transient tachypnea of the newborn cases and requires immediate intervention, including consideration of inhaled nitric oxide and extracorporeal membrane oxygenation. The critical clinical point is this. Any infant with an initial diagnosis of transient tachypnea of the newborn who develops worsening hypoxemia despite oxygen therapy must be urgently evaluated for persistent pulmonary hypertension of the newborn. This is why close monitoring in the first 12 to 24 hours is essential. Case 14. A 2-year-old child presents to your clinic with recurrent episodes of wheezing and cough over the past 6 months. The episodes occur mainly during viral upper respiratory infections and resolve with bronchodilator therapy. Birth history. The child was born at 38 weeks gestation via elective cesarean section without labor. The child developed tachypnea within 2 hours of birth with a respiratory rate of 75 breaths per minute and mild subcostal retractions. Chest X-ray showed hyperinflated lungs with prominent parahilar markings. Symptoms resolved by 48 hours of life with supportive care only. The child is otherwise healthy with normal growth and development and no chronic medications. Based on the neonatal history of transient tachypnea of the newborn, what is the most likely long-term respiratory association for this child? Option A. Increased risk of developing bronchiectasis in adolescence. Option B. higher likelihood of persistent pulmonary hypertension. Option C, elevated risk for childhood asthma and reactive airway disease. Option D, progressive development of restrictive lung disease. The correct answer is option C, elevated risk for childhood asthma and reactive airway disease. This is one of the most clinically important long-term associations of transient tachypnea of the newborn. Longitudinal studies demonstrate that infants with transient tachypnea of the newborn have a 2 to 3-fold increased risk of developing recurrent wheezing and asthma during early childhood compared to those without the condition. This association persists even after controlling for other risk factors such as family history and birth weight. Key research findings supporting this include a Danish cohort study of 1.2 million children showing 40% increased asthma risk at age 5 to 7 years, an Israeli population study showing higher rates of bronchiolitis in infants with the condition, and a meta-analysis from 2019 confirming a persistent association through school age. The proposed mechanism is early airway inflammation and remodeling triggered by retained lung fluid. Parents of affected infants should be counseled about this increased wheezing risk and advised to seek early evaluation for respiratory symptoms during the first 2 to 3 years of life. Are you looking for a structured way to access all of our pediatric case-based lectures in one place? Our pediatric case review community gives you exclusive access to organized learning that you will not find anywhere else. All videos are arranged by organ system, so you can easily navigate the entire library and study by topic in a focused way. In addition, all presentations used in the videos are available as downloadable photos, so you can review and practice all questions at your own pace, anytime and anywhere. We also offer an extensive practice question bank with detailed case-based explanations and a clinical resource hub with high-yield content for rapid review. If you are ready to join and want to know how to subscribe, simply comment below this post, and we will message you directly with all the details you need to get started. And that brings us to the end of today's lecture on transient tachypnea of the newborn. Let us quickly review the most important clinical pearls to take away. Transient tachypnea of the newborn is a self-limited condition affecting term and late preterm infants, with cesarean delivery without labor being the strongest and most important risk factor. On chest X-ray, look for hyperinflated lungs with prominent parahilar markings and fluid in the horizontal fissure. Most cases resolve within 24 to 72 hours with supportive care alone, and early recognition prevents unnecessary invasive interventions. Always monitor closely in the first 12 to 24 hours for the rare but serious complication of persistent pulmonary hypertension of the newborn. If you found this lecture helpful, please follow the Pediatric Case Review channel for more high-yield case-based lectures. If you have any questions or case requests, please comment below and we would love to hear from you. Thank you for watching.